Hello everyone. I'm Gayan Perera, I'm an epidemiologist working in South London and mostly BRC case register. Today I'm going to particularly talking about the association between loneliness and acute general hospital outcomes among patients receiving mental health care in South London. Particularly I'm using a database or electronic health records based in South London, and which I will be describing in the next couple of slides. So first of all, the loneliness has been defined as the distress resulting from perceived discrepancy between the individuals, the actual social relationships or contacts, or what they actually really want in future. So there's a huge impact of loneliness, particularly people with mental illnesses, and it's actually disproportionately affects the people with mental disorders. For example, 71% of the patients receiving psychiatric rehabilitation in the USA reported with loneliness as well. And not just the prevalence, also the cost of loneliness is huge in various parts of the world. And so my aim of the study was looking at or investigate the association of loneliness with acute general hospitalizations and mortality outcomes for those people who had contacts with mental health problems and receiving care in South London. So in terms of the methods, the most of the data is actually coming from 4 boroughs in South London. That's Southwark, Lambeth, Lewisham, and so the data is based in electronic health records at SLAM, South London mostly. And so in terms of the electronic health records, as of now, there are about over 500,000 case records are available, and roughly about 40,000 people as of now are active. That is, either they are not discharged from the hospital yet, or they are currently on certain investigations, etc. So one of the richnesses of this database is that there are lots of text information. The clinicians enter a lot of information, as you can see from the CRIS front end. So this richness of data qualitatively that can be turned into lots of information, and we have certain processes like natural language process, etc., so that we can actually turn this information into analyzable data. And also we have SQL data as well. There are about 6,000 fields and 125 tables. And so this can be analyzed and investigated. So going back to my study in relation to the loneliness study, and so we looked at all South London mostly patients age over 18. And as I mentioned earlier, they were all active at that time. That is, either they had accepted a referral or not discharged from services as of the index date was the 30th of June 2012. So the exposure was the recorded loneliness status. Again, I will describe the next slide about the loneliness status, how we actually ascertain that. And we ascertain the information between 2010 and 2012 June. And we then follow them up till 31st of March 2019. So the outcome we measured was the acute general hospitalizations. And also we looked at the mortality during this period. And we also collected various covariates at the baseline between just 1 year before the 30th of June 2012. So going back to how we actually collected the loneliness, we used GATE software. It's generalized architecture for text engineering software. And we created an algorithm using natural language processing. And then we search for various terms initially. That's, for example, lonely, loneliness, etc. And then we used a platform called Text Hunter and to obtain information. And it's an iterative process. We regularly looked at the words and how we can actually improve the accuracy or the precision or recall of those the text available. So we created developed a machine learning algorithm, and the precision for this algorithm was around 87%, and the recall at the end was 100%, and that is obtained from 500 records, and 2 individual annotators independently annotate those records. So in terms of other covariates, we looked at socio-demographic variables like age, gender, ethnicity, etc. And also we looked at the baseline as of 30th of June 2012, the mental health diagnosis, including serious mental illnesses, and substance misuse, dementia, etc. And we also looked at the health of the nation subcomponents, including agitation, self-injury, substance misuse, cognitive problems, etc. We also obtained the medication information, for example, psychiatric medication like antidepressants, antipsychotics, anxiolytics, and other medications like analgesics. Also, we looked at the acute hospital admissions previously, for example, hearing problems, osteoporosis, urinary tract infections, etc. So in terms of the outcomes, there were two types of key outcomes. That's one is hospital admissions, and the other one is the all-cause deaths. And in terms of hospital admissions, we looked at the emergency admissions as well as elective admissions. But for those types of admissions, we looked at the length of stay for the first hospital admission, and also we looked at the number of hospital admissions and time to the first hospital admission. So this particular table shows the loneliness recorded among just over 4,300 patients and not recorded among 22,000 patients. So roughly about in this cohort of 45,000 active cohorts, there are about 60 at that point we had about 27,000 and about 16% of them had loneliness was recorded. And in terms of the demographics, you can see those who had a recorded loneliness status slightly older and mainly female and less likely to be white, coming from white ethnic group. However, if you look at in terms of the honors problems, they have a severe health of the nation score problems. For example, they had severe agitation, substance misuse, cognitive problems, physical health problems, hallucination, and depressive symptoms. And in terms of mental health diagnosis, again, they had serious mental illnesses and depression, those who had actually recorded loneliness status. And again, similarly, those who had medication, particularly analgesics, those who recorded loneliness status, they have a higher prevalence of analgesics prescription, and antidepressants and anxiolytics were received more among those who recorded those who had recorded loneliness status. And in terms of the outcomes for acute general hospital outcomes, as you can see in terms of the emergency hospital admission outcomes, again, those who had recorded loneliness status, they had higher hospital admissions for emergencies. For example, 51% of those had emergency hospital admissions in the recorded loneliness group, compared with 42% those who didn't have any recorded loneliness. And similarly, there was a longer length of stay, high number of hospital admissions for both the emergencies and elective hospital admission outcomes. And in terms of the disease status, a slightly higher proportion of percentage of people have a disease who had the recorded loneliness. That's about 21%, compared with 18% those who didn't have any recorded loneliness status. And then what we did was we looked at the certain odds ratio, hazard ratios or incidence rate ratios to look at various strength of the associations. For example, time to event for the first emergency hospital admissions, we looked at hazard ratios, and after adjusting for various confounding factors, we found that those who had a recorded loneliness status were 15% high risk of admitting to the hospital early. And then similarly, the length of stay was longer for those who had recorded loneliness status. And also number of emergency hospital admissions were also higher among those who had a recorded loneliness status not just for the emergency hospital admissions, but also for elective admissions. But interestingly, in terms of the deaths, there was no significant association between those who had a recorded loneliness compared with those who didn't have a recorded loneliness status. So overall, the key finding is that roughly about 16.5% of the active SLAM patients or South London mostly patients had a loneliness was recorded, slightly lower than what findings are seen in other studies. Other studies roughly about showing there's a higher prevalence, like roughly about from about 20 to 30%, but our study showed slightly lower end. But on the other hand, in terms of those who had recorded loneliness, they had higher hazard of acute hospitalizations and longer duration of acute care hospitalizations, and also higher number of acute care hospital admissions as well. So probably if you look at the longer duration, there might be the complex issues. It might be, the people have, as you can see from the data, they have other comorbidities and severity of the mental health symptoms, or it might be related to, they don't have a place to go back, discharge from the hospital, such as, for example, they don't have a care home, or they don't have a place at home, etc. So our study demonstrated various trends. For example, electronic health records as this, as I mentioned earlier, as a given point, there are 45,000 active population. So we have a large sample size, and also in terms of the follow-up, it's near complete follow-up in particularly hospitalizations, as long as they stay within the 4 catchment borough areas. And also, as far as we know, this is the first study that utilized the natural language process to determine or detect the loneliness in routine healthcare records, to our knowledge. And however, there are various limitations, as we mentioned earlier. Natural language process is depend on, the clinicians actually entering the data of that particular patient. And also there are certain information is missing. For example, social support or contacts are not available through this particular process. So I'll stop at this point. I would like to thank my colleagues at the Islam BRC. Thank you very much.